Hello and welcome to the Retina Radar podcast. I'm Arshad Khanani, Managing Partner and Director of Clinical Research and Director of Fellowship at Sierra Eye Associates and Clinical Professor of Surgery at the University of Nevada, Reno School of Medicine in Reno, Nevada. In each episode, I'll be sharing information on the latest breakthroughs, clinical insights, and practical pearls for your everyday use. We'll hear from leading experts, explore cutting-edge research, and discuss the trends shaping our field. Whether you're in clinic, in surgery, or on the move, Retina Radar keeps you informed, inspired, and ahead of the curve. To earn CME credit, visit mededtalks.com, search Retina Radar, or click the link in the notes to complete the activity and post-test. Before we begin, please review the faculty disclosures and learning objectives. If you have a question for our experts, send it to us at cme@vindicocme.com, and it may be featured in a future episode. This podcast is supported by an educational grant from 4D Molecular Therapeutics, AbbVie, Adverum Biotechnologies, Alkeus Pharmaceuticals, Astellas, EyePoint Pharmaceuticals, Genentech, a member of the Roche Group, Neurotech Pharmaceuticals, Ocular Therapeutics, Oculis, Regeneron Pharmaceuticals, and REGENXBIO. Today I'm joined by my good friend and colleague, Dr. Glenn Jaffe, Professor of Ophthalmology and Director of the Duke Reading Center and Uveitis Service at Duke University. Welcome, Glenn.
Thank you very much. Pleasure.
We're honored to have you here today, Glenn. You're a legend in our field. You have done so much in terms of your contribution to the field, from imaging aspect, from clinical trial designs and execution. And we're really excited today to have you so we can have a discussion on diagnosis and treatment of macular telangiectasia, or MacTel. And I know you've been involved with many clinical trials for a long time, as well as looking at imaging biomarkers. So I'm really looking forward to our discussions. But just like every faculty that comes here, before we get into the topic at hand, we want to know a little bit more about Glenn Jaffe. So tell us your journey into retina and how you ended up doing what you're doing now.
Sure. Well, it was a little bit of a winding journey. My original mentor in medical school was a glaucoma specialist. His name was George Alvarado. He was very well known at the time at UC San Francisco. And as I went through my residency, he assumed that I was going to go into glaucoma. And in fact, the first paper I ever wrote was with George on a glaucoma topic. And while I was going through my rotations in residency, two people were extremely influential. One of them is Alex Irvine, who is the son of the person, Alex Irvine Sr., who had come up with the Irvine gas syndrome. And the other was somebody who was a very well-known retina specialist in the Bay Area in California, Howard Schatz. And they used to teach a fluorescein conference to the residents and were extremely enthusiastic and very influential. And the two of them were very motivational. And interestingly enough, Howie ended up becoming a world-famous fashion photographer and dropped retina completely, moved to New York with his wife, and had developed many innovative photographic techniques, but he was very inspirational for retina as well. And so as I went through, I had other co-residents who had come before me. Rich McDonald was one who was at UC San Francisco, another Bob Johnson, and they were also very encouraging. And one of my mentors was an ENT specialist. I thought I wanted to go into ENT. He was one of the co-developers of the cochlear implant. And I couldn't decide between ENT and ophthalmology. And I actually interviewed in both ENT and ophthalmology and interviewed for internships for general surgery and medicine, and went to Mass Eye and Ear once for the ENT interview and one for the ophthalmology interview, praying that luckily they were on different floors. I was just praying that nobody would see me from ophthalmology when I was interviewing for ENT and vice versa. But I finally said, this is ridiculous. I have to make my decision. And when I did the ENT rotation with these 8-hour head and neck dissections, that sealed it for me. And so that got me into ophthalmology, and then the rest got me into retina, and then the rest is history.
Wow, that's a very interesting story. Did you work with Robert Macomber too?
Was hired by Robert Macomber. I didn't actually work directly with him, but he was my boss when I first came to Duke. And so he was also obviously very inspirational, very creative, and was a very warm and engaging person, and just a wonderful person. And he was very encouraging for my career in the very beginning.
Wow, that's amazing. I can only imagine what that experience was like working with somebody who really created a vitrectomy. Wow. Okay, Glenn, tell us, what do you do outside your busy practice and doing Retina? What's your favorite hobby?
Well, I have a couple. I actually love to cook, and that I try food from all over the world and do that on a pretty regular basis. And one of the things that was a hobby, it's now just more for fun, but I was a biochemistry major in college, and I liked biochemistry, and I learned to brew beer. I learned to make microbrews from a biochemist at UNC, and I thought it would be something great that I could do with my kids. They'd learn how to do biochemistry and cook, and my wife completely put the kibosh on that. She said, no way.
Wow, that's very, very interesting. So next time I come visit you, I'm looking forward to some nice cooking, for sure. Okay, let's get to topic at hand. Can you summarize for our audience just the pathophysiology of MacTel and how our understanding has evolved over time, and of course, imaging characteristics on OCT?
Yeah, so it's a really interesting disease. And in the beginning, people thought of it as a vascular disease where you get telangiectatic vessels and you get leakage from the vessels. And it's now understood that it is really now thought more of as a neurodegenerative disease, and glial cells are involved. And so it's a neuronal degenerative process. And that's pretty evident when we see not only the leakage from the blood vessels, but we also see over time loss of the neural structures. Particularly we see cavitary changes that at first glance you might think is from leakage from blood vessels, but it actually are degenerative changes. And then you can see collapse of those cavitations. And then most importantly, or most relevant, I would say, to our current treatment is the loss of the outer retina, particularly the loss of the ellipsoid zone. That's one of the important hallmarks of the disease. So when we're thinking of diagnosing it, it's really important to differentiate MacTel from other simulating conditions, because clearly if you're thinking of a treatment for the disease that's particularly targeted for the neurodegenerative part of the disease, and you misdiagnose it and start treating for diabetic retinopathy or something else, you're not going to be treating appropriately. So I use a multimodal approach to look at the disease and try to differentiate it from other conditions. And that multimodal approach includes findings on fluorescein angiography, OCT, fundus autofluorescence, blue light reflectance, and color fundus photo and fluorescein as well. And so the typical things that we see on OCT, you can see loss of the ellipsoid zone in the MacTel region, or loss of the outer retinal layers. And the MacTel region typically is just temporal to the fovea, but it can progress to involve the fovea. Sometimes we see it nasally as well. And you can see on blue light reflectance, you can see hyperreflectivity. That's the equivalent of the red-free light on a Heidelberg spectralis system. You also can see on autofluorescent imaging a hyperautofluorescence centrally. And very importantly, and related to some of the things you consider if you're going to be treating, you can sometimes see a very dark hypoautofluorescent area that corresponds to pigment. And that pigment finding, which you can see on the color fundus photos, is an important feature because it signifies a later stage of the disease and potentially one that's evolving to develop neovascularization. The other thing we see on OCT, in addition to loss of the ellipsoid zone, correlates with the pigmentary changes that I said. It's not the same as the pigmentary change, but it often occurs at the same part of the disease process, or at the same time of the disease. And that is, you can see these hyperreflective mounds that look like they're sitting on the RPE, or you can see these hyperreflective lesions that look like antlers that project into the retina. And those are important findings because those findings are a sign of potentially developing neovascularization. And OCT angiography is another way to help confirm the diagnosis. So the other important imaging technique is with fluorescein angiography, and you can almost always see leakage from on the fluorescein in the MacTel region. And putting all of these things together will make the diagnosis. If you have diabetic retinopathy with leakage in the center, you don't see the outer retinal layers and the typical cavitations, for instance. So it's a pretty unique feature set that you really, I think, need a multimodal approach to clinch the diagnosis.
Well, that was a very detailed overview, and I loved it. I learned some pearls already from you, Glenn, and that's why it's great to have you here. Okay, so let's talk about ciliary neurotrophic factor, CNTF, implant, or NT501, that was recently approved for the treatment of MacTel. So tell us about the mechanism of action and how does CNTF, delivered via encapsulated cell therapy, is designed to preserve photoreceptor and slow disease progression.
So the encapsulated cell technology, I think, is a fascinating delivery platform. You can think of it like a gene factory in an implant. So these are molecularly engineered or genetically engineered cells that are designed to overproduce a protein of interest. So they produce lots of proteins like cells do, but they specifically produce one particular protein in particular, and that protein can be different depending on how you engineer the cells. And initially, some of the earlier studies were looking, for example, at releasing vascular endothelial cell growth factor, something that you'd have these cell factories that would release anti-VEGF molecules over a long period of time. The other thing that was put into these implants, most relevant to the current discussion, is a neurotrophic factor, cilioneurotrophic factor. And with our understanding that MacTel is more a neurodegenerative disease, CNTF, the idea behind the CNTF is to halt the progression of that neural degeneration. And so that was the basis for the NT501, the implant that's being used in clinical trials. And just incidentally, one of the other thoughts, which would have been great, was to combine an anti-VEGF agent with a neurotrophic agent so that you potentially could stop the progression of geographic atrophy that might progress along with treatment for neovascular AMD. And unfortunately, the treatment with an anti-VEGF molecule in the encapsulated cell technology ultimately didn't work. It didn't deliver enough of the drug, even when you put in multiple implants together. So that really hasn't gone forward. But the CNTF has been effective, and that was what was tested in the clinical trial.
Yeah, it's a fascinating technology. Before we go to the trial data, Glenn, just a quick overview of the surgical technique that is utilized to place this implant, because when retina docs sometimes hear about a surgical implant, they get worried. This is very similar to other implants we have placed in the eye, and I was part of both of these trials, CNTF as well as the anti-VEGF trial, and the technique is pretty straightforward. But can you give us a quick overview?
Yeah. So your statement about it being similar to the surgically implanted fluocinolone system is, I think, a really good one, because we learned a lot about the techniques for placing implants from that experience. And in fact, I was involved in some of the earliest discussions with the company that makes the CNTF implant when we were discussing how the implant could be placed and what we might adopt from the fluocinolone implant. And that actually goes back many, many years, predated these studies. And some of the things that we learned were that we wanted the implant to reside within the vitreous base, but we don't want a portion of the implant protruding through the sclera or eroding into the conjunctiva, because obviously that's a potential site for infection. And so some of the important features which were employed both with the fluocinolone implant and also most currently with the CNTF implant are having the implant hang within the inner aspect of the sclera. So there's a titanium loop on the end of the CNTF implant, which is analogous to the suture strut that's attached to the fluocinolone implant. And a suture is passed through either the titanium loop, or in the case of the fluocinolone implant, through the suture strut, and knots tied over it, so that when the incision is made, it will hang into the vitreous cavity adjacent to the inner wall of the sclera. And the suture that's passed through the titanium loop, or similarly through a suture strut, is then passed through the sclera at I like to put them at a 9/10 or more thickness, so that the implant is truly hanging within the vitreous cavity. And then that is tied down and secured, and the suture is placed on either side. And it's very similar to the fluocinolone implant. The technique that has been described for the CNTF implant is to leave the tails long, and then those are actually sutures placed on the end of the long tails. The reason is that if you use a Prolene suture, for example, it has a memory, and the tails will stick up and can potentially protrude through the conjunctiva, and you don't want that. I actually favor an alternative technique, but it works just as well, and that is when you close the wound and put a suture tied over the tails of the anchoring suture, and those are rotated to bury the knots, I will trim the tails very short so that they just barely protrude beyond the suture that's going around them, and then those don't stick up. So you can do it either way. You can leave them longer, or you can have them shorter. The other thing that retina specialists may not be as familiar with or do as often is to make sure that the conjunctiva covers the implant scleral site, because you don't, again, want any chance for infection or erosion. And so I think it's very valuable to actually make sure you close tenons over the site of the implant in addition to the conjunctiva to make sure it's very well closed. But it's a pretty straightforward procedure. You make the incision with the blade. You have to make sure that the pars plane is completely in size. You pre-place the suture, put the implant in, pass it through the sclera, tie it down to make sure the wound is tight, put the sutures over, the adjacent sutures tied over the tails of the anchoring suture, trim them, put the conjunctiva over.
That's a great summary of the procedure. And as I said, I've done several of these in numerous trials, and it's a pretty straightforward. Obviously, the care of the conjunctinon is important. And of course, we learned that from the port delivery system program. So I think most retina docs who have placed port delivery system are pretty good about dissecting the conjunctinons and hopefully avoiding erosions. So Glenn, let's talk about the clinical data in terms of the pivotal trials. And you led the reading center, you led the design of these studies, and you were involved very closely with it. So can you tell us a little bit about both of the pivotal trials that were done for CNTF implant?
Yeah, so first of all, one of the interesting aspects of this is one of the first times that an anatomic endpoint was accepted by the FDA where the endpoint was structural based on the loss of the ellipsoid zone, which we were talking about, with the rationale that loss of the ellipsoid zone means loss of the photoreceptors, means loss of function, and the FDA is very focused on function as an endpoint in clinical trials. And so they allowed as the surrogate for function the loss of the ellipsoid zone, which was maybe not the first structural endpoint. Actually, vitreous pharmacolysis study may have been the first, but at least that was a endpoint that could be measured fairly accurately. And so that at the reading center, we actually measured the area of the ellipsoid zone loss, and that was assessed over time, and it was tested in the treatment versus the sham group to look for the rate of loss in two different pivotal trials. There was a pivotal trial A and B, which are essentially identically designed. There really was no difference in the design of the clinical trials. And the important endpoint, which actually first was given with the phase 2 study, which gave statistically significant reduction in the loss of the ellipsoid zone in the treatment group compared to the sham, which set up the phase 3 studies of phase 3 A and B. And both of the studies met their endpoint. The endpoint being the significant reduction in the loss of the ellipsoid zone area. And this was assessed over a 2-year period of time, a little longer than some of our other studies. But remember, this is a fairly slowly progressive disease. Both the studies were positive, although the study A was more robust in terms of the outcome. It was a very strong p-value, less than 0.001. The pivotal trial B was also positive with a p-value of 0.02, but not as strong. Nonetheless, both of them were significant. And for those of you who are used to thinking in terms of complement inhibition, the complement inhibitor studies for geographic atrophy gave a difference somewhere in the order of 17, 20, 22, 23%, whereas this was more of a 40, 50% reduction. And so this was a greater reduction in area loss when compared to some of the complement inhibitor trials.
Oh, that's a great summary. And then any side effects to watch out for that were seen in those trials?
Yeah, so the first one to think about that you worry about in a surgical trial are complications related to the surgery. Unfortunately, those were very minimal. Things like endophthalmitis would be obviously a concern. That really wasn't a problem in the trial. But one of the things that was interesting, and it actually showed that the drug was working, is that the eyes that were in the treatment group had meiosis on the side that the implant was placed. And I don't know the exact reason for that, but it was a pretty consistent finding. And to me, it didn't really affect the patient in terms of function or anything other than, to me, that was just a marker that the implant was actually doing something. There also was some delayed dark adaptation, and this is on the order of 15, 17, up to 24%. And again, I'm not 100% sure of the reason for the delayed dark adaptation, but in general, the procedure was well tolerated, and patients are happy that have had the implant.
Got it. So appears to have very good efficacy for a disease that we don't have treatment for. And obviously there are some side effects, but they don't appear to be significant enough to stop the adoption because, obviously if this is a progressive disease and you have to find the right patients. So Glenn, tell us a little bit about who are the ideal patients for CNTF implant, because, clinical trials have inclusion-exclusion criteria for regulatory success. But in your experience, who are the right candidates?
It's a very interesting thing because this is a very slowly developing disease. And in some cases, patients don't even know that there's anything going on. And for me, the ideal type of patient was one that I've been following, that I have an idea of the tempo of the disease. So I know, is it progressing rapidly? Is it progressing extremely slowly? Now, the cells that release the drug have a very long lifespan, and the implants have been removed and they're still releasing drug out to 5 years or more. But having said that, we still don't know exactly what the lifetime is of the implant. And so a patient who is noticing some symptoms, somebody who is still relatively early in the disease course, but maybe not in the very beginning. And again, I'd like to follow them over a period of time. Period of time means not just a month or two, like 6 months, a year, 2 years. And most of the patients I've seen, I've had the opportunity to see the progression rate. One of the things that's important is to make sure that you're not too far along in the disease. And the patients that I told you about that have, or the eyes that have that hyperreflectivity, the mounds on the RPE or those antler configurations on the OCT, those are patients that were actually excluded in the phase 3 trial because it was found that in the phase 2 trial, they tended not to do very well. And they tended to develop neovascularization and didn't respond as well to the implant. And so somebody whose disease is progressing, who does not have signs of neovascularization, and particularly who don't have these hyperreflective mounds or antler-like configurations, ones who haven't developed cavitations that are so significant that they're in the fovea and affecting the vision. Those are the patients that I would consider for the implant. In fact, I just saw a patient who had the perfect appearance in one eye, loss of the ellipsoid zone, but not these other features. And they also tend to have pigment when they start to develop those hyperreflective mounds. Didn't have pigment, but the other eye had all those features. And so we're going to actually put the implant in the eye that did not have the hyperreflective mounds and the antlers, etc.
Those are some great clinical pearls, Glenn. Again, it's always great to learn from you. And now I have a better idea after this podcast how to select patients and what to look for in terms of diagnosis and obviously the surgical pearls and who are the right candidates. So excellent discussion, Glenn. I know we're running out of time, but before we close the podcast, we always ask our faculty two more things. Number one, what is the career achievement you're most proud of?
It's a little bit of a difficult question because my career has followed a little bit of a winding course. I have been involved in cell biology of first PVR and then macular regeneration and then drug delivery, and then more recently the work at the Reading Center and in clinical trials. I'm probably most proud of the work on sustained drug delivery because it was sort of the start of all of these new procedures and implants and platforms that we have. Just as an example, the very first fluocinolone implant we put in was a prototype that was projected to last 18 years in the eye. And in fact, we put that in and it lasted for years and years and years. It was just unwieldy you can't do a trial for an implant that lasts that long. But that started the other surgically implanted implant, and then the next thing we had worked on was the injectable fluocinolone implant and cyclosporin implants for horses, and then you're all familiar with the port delivery system. And I certainly didn't develop the port delivery system, but I think that these earlier studies paved the way for things like the port delivery and like the CNTF implant. And then most recently, I've been proud of the Reading Center we developed to interpret the images to help get these drugs into our patients and approved for use.
So in your Glenn Jaffe, you have a lot of achievements, and Glenn, I'm glad that you were able to kind of summarize your contribution to sustained delivery. But in my mind, you have contributed in so many different ways. Your reading center is the top reading center involved with the approval of majority of the recent drugs that we have and implants also. And of course, this was all taken in mind when you received the Professor Ramin Tadiani Summit of Excellence Lifetime Achievement Award at CTS 2025. So, and of course, you're a great mentor to many of us, and we always learn from you. So exciting to have you here. And the last question is, how do you want to be remembered when you retire, Glenn? And I'll tell you how I'm going to remember you, but you still have a long way to go. So tell us.
Well, I would say there are two different aspects. One is professional and the other is personal. So professionally, I've had the great fortune to be able to work with fantastic colleagues and also be able to work and help teach the next generation. And honestly, I think having a legacy of been able to at least influence in some small way the careers of the many people that I've been fortunate enough to work with, to me is really something I would like to be remembered for. And then I couldn't do any of this without, I have a wonderful family, and I hope that when I retire and they think back of all the experiences we've had, they'll think of me as a great dad and husband.
So definitely, I spoke to them when you received the award at CTS, and I tell you, they're wonderful and well-accomplished family for sure. From my perspective, you are one of the nicest guys in Retina. You just work. You keep your nose down and you work. I mean, you're not interested in limelight. You're not interested in anything. You want to do a perfect job at what you do and really move the field. So I think, from my perspective, I think it's hard to find smart, brilliant people with such a kind demeanor and such a passion for what they do. So that's how I think of you every time I hear your name. So Glenn, thank you for coming to Retina Radar podcast and sharing pearls about MacTel. I hope our audience learned a lot today from you, just like I did. I also want to thank the audience for listening in. Thank you, Glenn.
Well, thank you. It's been a pleasure, and I thank you so much for those kind words. I've enjoyed our friendship over the many years, and it's really great to be on the podcast with you.
Thank you, Glenn. To earn CME credit, visit medittalks.com, search Retina Radar, or click the link in the notes to complete the activity and post-test. Have a question for our experts? Send it to us at cme@vindicocme.com, and it may be featured in a future episode. Stay tuned for future episodes in the Retina Radar series to keep up with the latest insights and expert discussions.